Thank you all for coming here in your sharing your lunch hour with me, and also for the invitation to give this talk. I work, broadly speaking, in distributive justice or egalitarianism. A large part of my work is on the theory of distributive justice, but an important strand in my work, which has also been supported by the LSE, for which I'm very grateful, is much more practical and oriented towards shaping the policies of large international organizations. And what I'm about to present to you is part of work that I'm doing with people at the World Bank, the Norwegian Institute of Public Health, which helps set priorities in Norway, but also has a very strong capacity building and outreach program around the world, and a collaboration with the University of Bergen, especially their Bergen Center for Ethics and Priority Setting. And the question that I want to explore with you is, how can open and inclusive decision-making help achieve universal health coverage? Let me start with some definitions, because you might wonder, what is universal health coverage mean? In a nutshell, it's everyone having access to, at minimum, an appropriately designed package of necessary health services, and that they have this access without having to fall into grave financial distress or difficulty. So it's about access, not to everything that might be useful to a person, but rather some appropriately designed minimum basic healthcare package, at least that, and moreover what the appropriate content is of this minimum package, I think, should be determined in relation to the resources available in a country at the time. So universal health coverage in, say, Norway, which is one of the countries which has the highest per capita funding available for health, around $10,000 US, should be different and is more demanding in terms of the package supplied than in a country where I've also worked, Ethiopia, where last time I checked the per capita budget available for healthcare was $27. Right? So imagine that huge difference. So the idea is, appropriate for each amount of resource that we have available, we can attain universal health coverage by providing a minimum well-designed package, access without, in such a way that people don't fall into financial distress. Now, this is a major aim that nearly every country has signed up to, and it's also a major commitment of the World Health Organization. It's also among the World's Sustainable Development Goals. So that's why international organizations are interested in pursuing it. And what is health financing? Health financing is, in essence, the raising of revenue to pursue universal health coverage, the pooling of different people's contributions into a single pool from which health needs are met, or at least some pools, but in the ideal, a single pool. And finally, the spending of that money on priority interventions. So it's revenue raising, pooling, and purchasing from the pool for the population. So understood, the aim of making progress towards universal health coverage can be visualized in this cube, which comes from work by the World Health Organization. And you see there are three dimensions in the cube. On the horizontal axis, there's population, share of the population that's covered with existing coverage mechanisms. Then, if we go back, the axis going back is services. Imagine you've ordered the services that are being provided to your population, perhaps from high priority to lower priority. And then finally, and again, you could imagine that going further along that axis. And then finally, it's how much is covered from pooled funds rather than paid out of pocket. That's the third dimension. And in essence, what you want to do is grow this yellow area by moving forward along these different dimensions as your resources allow. The content of that yellow area is basically what you've got in order to cover your population for services up to a certain share of their expenditures. Now, obviously, this question of how to make progress along these different dimensions involves challenging trade-offs. Some people are favored over others, for example, by particular decisions. It involves questions of what we call substantive justice, which is about the justice of who gets what, whose needs are prioritized when we cannot meet everyone's needs at once. That question of substantive justice, the justice of who gets what, how people end up, was covered by a previous report, which I co-authored with others, called Making Fair Choices on the Path to Universal Health Coverage. The report I want to talk to you about now, the collaboration with the World Bank, is not about substantive justice, but a different component of justice, procedural justice. Who decides who gets what? Whose interests are heard? Whose voices are listened to? And how does the deliberation or decision-making take place when we make these challenging trade-offs on the path to universal health coverage? So that's the report, Fair Processes for Financing Universal Health Coverage. What was the nature of this work? Well, it involved, of course, several stages. The first is there was a small team writing it from different participating institutions. I'm one of 7 authors, but we didn't want it just to reflect our points of view. That would be pointless. It's meant to be something that potentially could guide policymaking around the world and by major international institutions. So we wanted to hear a diversity of perspectives, so we had several expert consultations with people from many different countries. Then we did also a literature review, because the concept of fair decision-making, understood as fairness of the procedures, has application in many different areas. There's social psychological research about this. There's research in what's known as participatory budgeting. There's research in environmental studies on local consultation, for example, on the design of environmental interventions. There's, of course, also research in health. So what we tried to do is do a literature review, what's known as a scoping review, in which we attempted to distill from hundreds, maybe even, it was a team reading it, so maybe even thousands of articles, some core principles which I'll present to you. And then we looked at country case studies. We commissioned a series of groups of authors from around the world, from all over the place, to see if the principles that we had articulated for open and inclusive or fair decision-making were implementable in a variety of contexts, and what barriers might arise in attempting to implement them, but also what costs it would have to implement them, or what costs it would have not to use fair procedures. Finally, there's the report, and then there's follow-up analysis, debate in both academia and with policymakers. Where are the case studies? Well, you can see they're from all over the world. So Ukraine, the Gambia, Mexico, South Africa, Thailand, Kerala, a state in India, basically trying to look at a variety of different types of health financing decisions. So sometimes revenue raising. So we looked at sugar taxes in Mexico and South Africa, for example. Sometimes on what is purchased by the health system. So the Kerala case study focused on increased investment in primary health care, and sometimes in total health sector reform. The Ukraine case study, on which I was a participant, a co-author, looked at the process of changing from the Soviet-style health system, which was inherited after the 2014 Maidan revolution against more Russia-centric government that they had at the time, to what was called the National Health Service of Ukraine, modeled roughly on a kind of NHS-style health system. So all kinds of different policies, all kinds of different circumstances. So what are we proposing it characterized as open and inclusive decision-making? We came up in the end with a kind of hierarchy of principles. We said at the core, at the foundation, are 3 principles. One is equality, the second is impartiality, and the third is consistency over time. And I'll say a little bit about at least the first 2 of those. Equality here is understood not in a material sense, about individuals getting as much of one or another thing, because that's the issue of substantive justice. That's not the focus of this report. Instead, it's equality of voice in the sense of equal ability or opportunity to contribute to public decision making, to have one's ideas and opinions heard, raised, and listened to respectfully, where listening respectfully doesn't mean agreeing or taking on board, so to speak. It rather means taking the best version of the reasons that you're offering me and then engaging them with them, taking them seriously, not just dismissing them or ignoring them, nor merely accepting them, but rather being prepared to assess them with you, in dialogue with you. That's a notion of equal consideration, equal opportunity to have one's voice heard, and especially when you take this notion of equal opportunity to contribute seriously, it's clearly directed against forms of exclusion and marginalization, which are very common in all forms of public decision making. Impartiality is understood as meaning that the decision maker's own interests should not unduly sway the decisions that are made. Rather, they should flow from impartial concern or impartial considerations in question. I'll give you an example to make this vivid. In one study that informed our report, in Malawi, there was a case in which a new formula was going to be proposed for allocating health resources to the regions. And they brought all the regional heads together, and they thought, look, if we simply identify the different regions and how much they're going to benefit or lose from this new funding formula, everyone is just going to fight for their own region. So instead what they did is they anonymized the regions, and they said, we propose to discuss only general formulas which have as their input, so to speak, the population in a given region, some notion of health need, is there a high birth rate, are there many old people, and so on, and some other general characteristics of each region. And then we're going to talk about those and see how they impact these anonymized regions characterized only by these key factors. That was to force the deliberation to be more impartial than it would have been if it had been named regions and every chief would just be there pressing for their own region. Consistency over time simply means we apply the same type of principles over time. It's in essence, an idea of alike should be treated alike. Now, these are the foundational principles. Then we also came up with 7 practical criteria in 3 domains. One domain is the information domain. So good decision-making should be based on a kind of dialogic understanding of reason giving, reason exchange, which is, of course, flows from this idea of equality, the aspect of respect that I mentioned at the beginning just a moment ago, that ideally when we make public decisions, we don't just communicate to the population, this is the decision, now deal with it, but rather we offer reasons for it, the rationale for the policy. But in addition, this is preceded by a period in which there's an exchange of reasons for and against the policy, rather than merely unidirectional communication of reasons. So reason giving here is understood, at least in the ideal, in a dialogic manner. Then transparency involves making clear what is decided, why, and also how people can follow up on the things that have been decided, whether they're actually going to be implemented. And accuracy, and I should add also completeness of information being a key characteristic, namely, we never have perfect information about policies, but we should try to base policies on the best information we have available. Second dimension is the voice dimension, the voice domain, which is in essence a kind of implementation again of this equality and impartiality criterion, where what voice requires is not merely that your interests are, in a sense, abstractly considered, but actually that you and your perspective on your interests, or some representative who can speak to your interests and your perspective, is heard in the process. That's what the notion of voice means. Again, connecting, all these different areas are connected. The reason giving is essentially connected to voice, because I can only enter into dialogue with you if I'm hearing you and or a representative for you. And participation is about making sure that each person can actually, or say groups that represent them, can actually participate, not merely that, so to speak, the door is open, but that a number of barriers, for example, distance to a place where a hearing might take place, different levels of education, or poverty which prevents you from having the resources and time to come and contribute, that these are overcome. Finally, this shouldn't just be the commitment of the decision makers based on their goodwill. We should have institutions which ensure that this process is monitored and that any errors in the process can be challenged and therefore decisions can be revised on good grounds. That's the oversight dimension. Now, in the ideal, satisfying all these 7 criteria as an expression of the 3 foundational ones is very demanding. And you might think, and this is partly one of my worries when I started this process, this is far too idealistic. Indeed, it's utopian. No country, even established democracies, can meet this fully. 2 important insights emerged for me from this process. The first is that these things come in degrees, just like substantive equality comes in degrees. Reducing inequalities in how people end up, or what their level of well-being is not utopian, so long as we recognize that inequalities can be worse or less bad, and we can make progress along dimensions of equality or reducing inequality, just as we can worsen it along that dimension. So similarly, the form of equality that's relevant here, and transparency and reason giving, each of them comes in degrees. You can have completely closed authoritarian deliberation. You can have fully open and inclusive deliberation. And again, we can tweak and adjust according to circumstances our institutions so that they meet them to a greater or lesser degree. One fascinating thing for me was that some of the case studies which showed the greatest success, at least in certain areas, were in authoritarian or not fully democratic countries. So the Thailand case study, which you can, by the way, you can read all the case studies in a recent issue of Health Policy and Planning if today has whetted your appetite. Thailand was at the time not a fully functioning democracy. In fact, there had been a military coup. Nonetheless, within the health sector, they had invested very heavily in institutions which allowed participation from even very marginalized groups. And indeed, the policy in question, which was the provision of pre-exposure prophylaxis, which is in essence a taking of a drug which prevents you from acquiring HIV when you're in a high-risk, have a high-risk lifestyle. For example, you're a sex worker. If you take this while you do not have HIV in a low dose, it stops you from acquiring HIV. Now, these are, of course, among the most marginalized people in the population. Their representatives were heard, and an important part of the decision-making process in Thailand was to invite them to the table and have groups representing them, civil society organizations, present in shaping policy. So one can make a lot of progress along some dimensions in a particular sector or on some issue, even in a non-democratic society. That was an important takeaway for me. So why did we argue that this is valuable? And I'm going to propose 4 values to you and then mention some drawbacks. The first was simply that it can contribute to fairer, more effective policy. The basic idea here is this. If one of the major reasons why policies are systematically and do not serve the interests of the poor and marginalized is that their interests are not heard, their voices are not heard, and their interests are not considered. If you have a decision-making process which does ensure their voices are heard and does make sure their interests are fairly considered, you're likely to eliminate at least one source of their disadvantage. Right? So there's going to be a correlation between improved voice and participation and the substantive fairness of the outcomes, even if the two can in principle come apart. And the other is, if you hear people and their interests, you're much more likely to get an accurate view of their situation than if you do not hear them. There are many different diverse sources of information. There's the information that technocrats like to hear, right? The things you learn at LSE when you're taking a course in public policy, for example. And then there are other sources of information, like lived experience of a sex worker in Thailand. Who among the normal priority-setting panel in Thailand knows of that lived experience? No one. Right? Therefore, it's essential that you hear from the people whose interests are at stake in the decision in order to craft it on the basis of good information. So the same can be said about many of these dimensions. The Thailand case study here being an example. What was important in Thailand is it wasn't one-off. It was part of an institutionalized program of hearing the populations and their representatives' voices in such things as what should we cover on the universal health coverage package. They have well over 100 individuals in the Thai government employed to work on citizen participation. The second advantage is it strengthens legitimacy. Because a fair process, at least in the ideal, treats people with respect and considers their interests and ideas equally, it enhances the degree to which they have reason to accept the outcome. Because if an outcome is the result of a fair process, even if it goes against what you would most want, you have reason to accept the outcome that you wouldn't have if it was simply the judgment of a closed process where you weren't consulted and you couldn't hear the reasons offered for the policy. And interestingly, so that's a normative claim that you have more reason to accept a policy when the process that has led to its implementation has been fair. The psychological claim, when we review the social psychological literature, is de facto people do accept, are much more willing to accept policies even when they go against their interests, when they think the upshot of a fair procedure where fairness is understood in the way that we define it here. So people, for example, are much more willing to pay their taxes when they think that the process leading to the tax rate imposed on them, even if they don't like it very much, has been a fair one than if it's merely imposed on them without any consideration of their interests. This is a quote from the social psychological literature review. So, better policy in the sense of based on better information and avoiding some of the reasons for inequality, more legitimacy. The third dimension is building trust. When your decision-making is transparent, when you offer reasons, when you consider people's interests impartially, people have greater grounds for trusting your decision-making. So that's the essential connection between trust and open and inclusive decision-making, because it allows people to challenge, to check decisions, and because people can trust that their interests have at least been heard or considered rather than merely set aside and dismissed. Again, the Thailand case study is reported to many of these case studies also involved interviews with participants or representatives in society, reported higher levels of trust in the priority setting done by the Thai government precisely because of its inclusive nature. And the fourth advantage is improved sustainability, not in the sense of environmental sustainability, but durability of reforms. Health reforms, especially health financing reforms, often take a very long time to bear fruit. So I like to compare it to things in the United States, for example. Obamacare, which attempted to move the United States very far towards universal health coverage, which imposed on people a requirement to purchase a minimum package of health coverage, and the handing out of $1,000 or $2,000 under both Trump and Biden to deal with to each individual, each taxpayer, during the COVID pandemic. The latter is a one-off policy. You've got the money in your pocket now. Hopefully you will spend it to stimulate the economy. Right? It doesn't rely for its impacts or effectiveness on an extremely long-term institutional change. Changing your health financing system or introducing something like Obamacare requires many years to bear fruit, and therefore if it's immediately challenged by the next government which attempts to undermine it, it may be fragile and never actually get any results at all. And in fact, they may just be counterproductive. Because health financing has this long-term institution building aspect, it's very important that people in the population as a whole and various stakeholders come to understand the reasons for it, the rationale, rather than merely see it as imposed on them, because they're actually accepting, to some extent at least, the reasons for the policy becomes essential for its enduring support. Here, an example from the Netherlands. Our version of Obamacare took 10 years to negotiate across many different political parties, involving almost every stakeholder. Now, that is an extremely long time in politics. They say a week is a long time in politics, so 10 years. But it's endured ever since. So this was brought in 2006, was never significantly challenged afterwards, was tweaked but not challenged. And we're heading into 20-year anniversary for this reform which brought in universal health coverage in the Netherlands. Of course there are costs. Right? So I've given you the benefits. What are some major costs? Well, the first is who has 10 years? Right? I've just gave you the Netherlands as an example, 10 years. Ukraine, one of our case studies, they felt we had an extremely short window to totally transform a Stalinist, non-performing health system into something more like the NHS. Okay, we don't have time for 10 years of consultation. 10 years later, I mean, now you're in the midst of a war with Russia. Right? They needed to move fast. So do we always have the time? The second is, I talked before about opening up in degrees. But of course, if you open up in degrees without equalizing the playing field, what you might sometimes have is the powerful interests jump in first and hijack your supposedly open and inclusive deliberation. And so in the Mexico case study, we saw that on purpose, they did not have open consultation on whether to introduce a sugar tax, precisely because they thought, if we have open consultation, what's going to happen? The sugar industry is going to be in there from the start, and they're going to determine the entire agenda, and they're going to sink it. The third is, if you don't have good institutions, like, for example, Thailand did for public consultation, then even with the best will in the world, the implementation is going to fall short. So the Gambia case study, a country in democratic transition, they wanted a large reform of the health sector, they wanted open consultation. In essence, they didn't have the time, the manpower, and the know-how on how to do it. In fact, they sent invitations to the wrong people to show up at consultation. The Regulatory Council of Nursing was invited rather than the nurses' union, for example. So the nurses were never heard. Not a matter of ill will, simply a matter of lack of knowledge in a transitioning country. So what then is the key recommendation? If you want this to succeed, if you want to get these 4 benefits that I outlined of open and inclusive decision making, it needs to be a long-term investment in 2 things. First, in institutions that are genuinely open and inclusive, and that involves resourcing them properly. And secondly, in relationships social relationships and what's called by some scholars deliberative capital. That's to say, a willingness to enter into the type of open and inclusive decision making along with others whose views may be very different and opposed to your own. If you don't have that degree of social trust, it becomes extremely difficult to make a success of this. So thank you.